The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Thank you for taking the time to join us for this lung ultrasound webinar in the era of COVID-19. Hopefully, it'll be a treat for everyone. I think there's something for everyone in this webinar. It's educational. Can't say it's entertaining, other than the fact that we have a rare treat that we'll get to see in kind of small aliquots. We get to speak with a physician who is battling COVID-19 on the front lines in Italy. And we'll go ahead and get started. At the end, there'll be a time, hopefully, for people to write in their questions in the question box, and I'll try to get to as many of them as possible. For now, please enjoy this webinar. We're going to have a number of objectives today. We're going to discuss lung ultrasound use in COVID-19 patient evaluation, discuss some of the patterns that may be seen on ultrasound, try to correlate them with CT findings. We'll also talk about lung ultrasound finding challenges, what can go wrong, what are pitfalls. We'll talk about B lines, comet tails, and the pleural line especially. I think we'll go into the weeds just a little bit to make sure that everyone is aware of the vipers that are in those weeds so people don't get caught, or simply are more precise with their evaluation and diagnosis. And as I mentioned already, we have an interview with a frontline physician in Italy using lung ultrasound that we conducted yesterday and are very excited to bring to you. Sadly, COVID-19 is spreading like wildfire everywhere. These are the latest numbers from the CDC. As of about an hour ago, our cases are mounting, and I think this is what we can expect. While some countries around the world may have peaked or starting to recover, many others are just starting this epidemic, and the graph, I think, adequately shows what we may be in store for and the diagnostic and managing challenges that we can have from this disease process. Well, how can lung ultrasound help? As we know, a lung ultrasound on a normal set of lungs is kind of boring. In fact, I always dread showing lung ultrasound to a novice that's eager to learn because they want to see something neat. And normal lungs really are not that neat, especially if you're not used to the images. However, lung ultrasound has really been thrust into the forefront in our battle against COVID-19. I think rightfully so, but we should explore why and if that's true. Here's an interesting lesson for ultrasound from CT findings. This is one of the first kind of studies that came out and positions. And basically, initial radiology literature on chest CT suggested that COVID-19 lacked specificity. Findings overlapped with adenovirus, possibly other processes, the flu in general, and this may not bode well for ultrasound, although they are different modalities. We quickly saw some recommendations from our radiology colleagues that POCUS should be used for COVID-19 diagnosis and monitoring the lungs. And it makes sense. If the CT scanner is down for an hour after each possible patient for decontamination, it can really destroy the workflow for our radiology colleagues and the entire medical center. Now, we have seen some interesting studies released, and luckily, there's light at the end of this tunnel, potentially, as far as the diagnostic tunnel anyway. A study that just came out looking at deep learning to evaluate chest CT results from China may hold some promise. Quite a few chest CTs, 4,300, and they basically compared two different deep learning algorithms. I won't go into that, although it's a favorite topic of mine, but suffice it to say that the area under the curve for identifying correctly COVID-19 pneumonia was 0.96, and for community-acquired pneumonia was 0.95, and they obviously did very well also in determining that there was nothing wrong or other pathology. The areas under the curve are reported here and really are very impressive. So impressive, it makes me wonder that ultrasound may do quite well as along with CT. Now, something that applies to ultrasound is the fact that there is evidence that lung lesions for COVID-19 pneumonia patients are found in specific locations. And some of these locations are just prime for lung ultrasound evaluation as part of a standard lung ultrasound exam. When you look at the symptomatic cases, many, 80%, will have lung opacities that are noted on CT. And interestingly, and we'll talk about this a little bit later, in asymptomatic cases, a good portion will have lung lesions present as well. Many studies that have come out looking at CT have shown similar results. Look at these peripheral lesions. What's important about that? All of these infiltrates touch the pleura, and of course, lung ultrasound can see things that touch the pleura. If we had a lesion in the middle here that did not touch the pleura, we wouldn't see it with lung ultrasound because all we see is the pleural line or the sliding pleural interfaces, and we don't see anything deeper of any substance. Now, here's a nice video. All of this is off the internet, and it really shows us the lesions. Now, it's interesting, not only are they peripheral, but many are posterior, quite posterior, and this is an important thing to take forward in the next few slides. As I mentioned, we had a chance to speak to Dr. Caroselli from Italy. He's an accomplished clinician and sonologist. He is well published. He does not have any connection to Econos, is not endorsing any products. He's not representing any facility or entity. He's just sharing his personal views with us. And I think we'll learn a lot from this. I've decided to break the overall interview up into multiple short clips and interspace them so that we can get the most out of all the important things he's saying. I am here today joined by Dr. Caroselli. He is a frontline physician in Italy dealing with COVID-19 patients, scanning them, managing them every day. And we wanted to get a little bit of his experience with ultrasound and have asked him to join us for a series of questions. Good afternoon, Dr. Caroselli. How are you doing?
I'm fine, thanks. And you?
Very good. Thank you so much. Thank you for joining us.
Thank you.
I wanted to start out by asking you how long you've been using lung ultrasound in general, and how often do you do lung scans on patients before this whole COVID-19 epidemic began?
I've been using lung ultrasound for about 12 years until now. Before COVID infection, I used it to scan lung very, very often. Each time I used the stethoscope to examine the lung, I used the lung ultrasound. Because really, I think that lung ultrasound is a precious improvement of the physical examination, and is very, very important.
There is some lung ultrasound literature that's already come out based on COVID-19 patients. There are several opinion pieces that are very important, but one in particular out of China looks at 20 COVID-19 patients, and the authors compared ultrasound results with chest CT results, which is kind of interesting. And although it's a very small sample, I think this study is very educational. The authors found particular signs in COVID-19 patients, and they were very much related to the findings that radiology found on CT scans. Obviously, B lines and similar things could not be seen on CT because of the different nature of the modalities. But they noted that there is often thickening of the pleural line and irregularity of the pleural line, B lines in various patterns, various consolidations, different shapes and sizes. And interestingly, out of these 20 patients, pleural effusions were not frequent as opposed to other pneumonia patients that we'll see on a daily basis. Now, it's interesting. Some traditional approaches to scanning the lungs have left out the posterior thorax, but as we saw in both of those CT images, rather the image and the clip, it's more important than ever to scan the posterior aspect of the lung on both sides. And I think there's some suggestion from the current literature on that as well. So what is a possible scanning protocol? Starting out with the right upper quadrant, looking just above the diaphragm, going higher into the mid-axillary line or into the axilla along the mid-axillary line, then coming in the mid-clavicular line, lower chest, upper chest, and then getting the back, which not everyone is used to. But clear from current literature on COVID-19 and other ultrasound literature from non-COVID-19 patients, this may allow us to catch more lesions than if we're only scanning the anterior chest and the lateral chest as well. What areas or regions of the lung are you scanning in most patients when you are able?
I suggest 12 areas, 6 years for the left, 6 years for the right lung. So each lung has you can consider each lung 6 areas. A mid-clavicular upper chest, a mid-clavicular lower chest, and then a mid-axillary upper chest, and mid-axillary lower chest, and posterior upper chest and the posterior lower chest. So for the right lung, for the left lung.
Now, we have some videos of COVID-19 patients. All of these have largely come from the internet. They're out there. I just thought I'd put a few of them together. But interestingly, all of the findings described on lung ultrasound in COVID-19 patients are really common findings to lung ultrasound on a daily basis. It may be the pattern and the severity that's different, and time will tell. But there is a new focus on the pleura and B lines, as you'll see in the literature and also from our discussion here. We know that thickening of the pleural line and irregularities are common, B lines in various patterns, various consolidations, and this is a common one that's described. This is an actual subpleural consolidation from a COVID-19 positive patient. And again, the one I found really interesting, that there were very few pleural effusions, although keep in mind the sample size was rather small. What type of lung ultrasound findings are you seeing in patients who turn out to be COVID-19 positive on testing?
This is a very interesting question. In my experience, in this time, lung scan identify a diffuse B pattern, but we can see also focal B lines or fused B lines evolving in a white lung. About the pleural line, the pleural line is very important because we can find this continuous RAB appearance to the pleural line. And we can see also a posterior superior consolidation. Interestingly, the disease consolidation are localized in the lower areas of the lung, moreover in the posterior lung areas. So we can see different pattern, but common pattern is B lines.
Now, there are also anecdotal reports coming in that patients without any respiratory symptoms have abnormal lung findings, such as this, some irregular pleura and some subpleural consolidations, as is depicted in this patient in this ultrasound. And I've heard this really from both coasts and actually internationally as well. Patients that don't have any respiratory symptoms were triaged in the non-COVID-19 category historically and clinically, were then scanned for some reason, typically educational, a couple of times by accident is my understanding. Such abnormal findings like the subpleural consolidation and thickening and irregularity of the pleural line were identified, and then the patient was tested, even though they had no symptoms, and came up positive. This was surprising to each individual that was caring for them that I spoke with, and I think this is happening in other people's experience as well. And remember that CT study, which showed consolidation or at least lung lesions in almost 50% of asymptomatic patients. Are you scanning patients with very few or no symptoms, or just confining your scans to patients that have respiratory symptoms and maybe are more likely to be positive for COVID-19?
Honestly, I am scanning also patients without respiratory disease symptoms, because we know that this virus can be evident also without other symptoms like diarrhea, like fever, just diarrhea, or articular pain. And so not necessary from the beginning with the respiratory diseases. So I think that we have to pay attention also to the other patients with different symptoms from the respiratory. So for now, I think that this is a good thing to scanning more patients if we have the doubt that the patient can be COVID positive, because just one patient can contaminate a lot of people, so we can't risk.
And this is very interesting. Can lung findings help us? Sounds like the answer is yes, but can lung findings confuse us as well? There's been a realization amongst some of the lung ultrasound experts in the world that we need to look at the pleura more closely. And in fact, there is a paper that has been submitted to a major journal discussing this by some of the preeminent lung ultrasound gurus in the world. Hopefully, it'll be accepted and come out this fall because it specifically addresses some of these issues. Traditionally, many providers, including myself, have viewed B lines as present in all sorts of pathologic states, including pulmonary edema, lung fibrosis, infection, and other processes as well. There's lots out there in the internet about patients having B lines like pulmonary edema, just like pulmonary edema. The question is that accurate or not? And in fact, if you look at this area here, it looks like there's a B line coming down from the pleura of this patient who is a COVID-19 positive patient. But if we look at the pleura there, we may actually have a different answer. And that answer should be one that this is very separate from a B line that is seen with pulmonary edema, and we shouldn't confuse it. On closer inspection, in fact, most of these may not be actual B lines, and the pleura really does hold the secret. I think we need to consider two separate reverberation artifacts, and this is nothing new. It has been described by some of these legends in lung ultrasound repeatedly. This is just one example. And one could break these into B lines and comet tail artifacts. The artifacts can be ill-defined or well-defined, long, short, bright, smooth, have a variety of widths and shape. And all of those probably should not be lumped into the same category because they likely have different significance and different origins. Further, we had Dr. Kamada from Japan and his colleagues take a good look at the origins of B-line artifacts and some of the ultrasound settings and adjustments that can affect them potentially negatively and impact the precision of our scanning. And we'll go into that just a little bit, but it's a very separate, interesting topic if you want to delve into that further. Dr. Lichtenstein, who is truly a genius, I've had the pleasure of meeting him several times, reading his articles. The first article I read of his, I believe it was this one, was in 1999, and I tried to start scanning lungs. I started point-of-care ultrasound in 1993 and had not really looked at lungs before, but this was an eye-opener for me, and I realized what a genius he was because I could never really understand more than just the basics of ultrasound. Would have to ask him repeat questions at meetings and read more and more, and still I don't think I really understood it well. Now, Dr. Lichtenstein described a comet tail artifact, and his colleagues did in their original publication, or one of the early ones, the 97 one, and they felt it allowed distinction between pulmonary edema and COPD, which is a big deal. They felt that there was only one long type of comet tail artifact that was diagnostic for interstitial syndrome, and thickening of the interlobular or interlobar septa at points of greatest impedance was likely the explanation behind these comet tail artifacts. One thing to consider is, having spoken with Dr. Lichtenstein about this, and having seen his presentations, he used a very efficient, cost-effective machine that I believe dated back to 1984. So it was a fairly rudimentary piece of ultrasound equipment and may not have allowed him and his team to appreciate changes at the pleural line, which researchers with modern equipment now have the benefit of evaluating more closely. And today we can just see so much more on our ultrasound examinations. Thus, because of the limitations in the past, parenchymal lung disease may not have been quite as obvious. But for us, parenchymal lung disease has to be excluded before assigning all artifacts to the B-lines category from pulmonary edema. And I think we'll get into this in just a little bit and hopefully clarify this issue. Before we do, it's important again to bring us back to Dr. Cometa's study, and this is a great one that he did and published, and looked at all of the effects that different settings can have. So you not only need a transducer that can image maybe to 25 centimeters, especially with some of our heavier patients, but define the near field at 3 to 5 centimeters in depth, or you have to use 2 transducers, but obviously that affects your workflow. And now with the decontamination measures required, that really increases your time. If you don't have your settings correctly, such as having the focal zone too low, it can artificially widen B lines. It can multiply B lines if you use compound imaging. And Dr. Cometa showed all of this very well in tightly controlled experimental settings. Thus, we want to make sure the transducer not only has the right presets, the focal zone is placed at the pleural line, but we also hold the transducer such that the ultrasound beam emanating from it perpendicularly intersects the surface of the lung and does not come in at an angle, because that can affect the image quality. True B lines should originate from a smooth appearing pleural surface. They're caused by edema within the interstitium, and they should be well defined and stable in width. Recall the prior slide that showed B lines widening significantly or even multiplying after they emanated from the pleural line. They should be hyperechoic and extending at least 10 centimeters in depth and potentially more. There's a caveat to this. If you don't have all the post-processing turned off on modern machines, a lot of times if you have the depth to 20, 25 centimeters, everything at the bottom of the screen seems to be wiped off. So make sure you have the right preset or at least the right adjustments on your machine. Comet tail artifacts, however, are found in many other processes. They typically correspond to processes that cause an irregular and interrupted pleural line. If we look here, look at how irregular it is. It's thickened in some places, very different appearing, but at first glance, you have these B lines that emanate from it. And it's easy to say this must be pulmonary edema, but it's not. Thus, if a reverberation artifact arises from an irregular or interrupted pleural line, goes down 10 centimeters or more, changes in width, and we are seeing that somewhat here, it is likely to be a comet tail artifact rather than a B line from pulmonary edema. And this is how you can tell pathology apart. This pleura appears to be maybe normal with a B line, but when we look at it closely as the video pauses, the arrows show that the pleura is quite irregular, and this B line almost seems to originate below the pleural line. That's really an example of highlighting that that's not a B line, but a comet tail artifact, a different animal, whatever name you choose for it, and it is associated with a different pathology or set of pathologies in the lung, and specifically at the pleural surface in this case. Comet tail artifacts can be mistaken, especially if you're looking quickly at the pleura going by. It looks thin, normal B lines, but then right here, we start seeing a little abnormality, a thickening right about there, and you can see it right in this case. And notice the difference. So you seem to have some normal pleura maybe, or at least not quite as abnormal, next to this abnormal area. And this was a patient that had a sarcoid in actuality. This is a better example of very disrupted pleura, really kind of that uneven pleura, subpleural consolidations that we've seen described in COVID-19 patients, and hopefully it's much more obvious. You can see B lines that originate from this disrupted pleural line and consolidation. Clearly, this should not be considered a case of pulmonary edema with B lines, but rather comet tail artifacts, as the leaders in a lung ultrasound, I think, would suggest. At least some of them would. Another example where just moving the probe around, the pleura almost appears normal at one time, then clearly is abnormal, interrupted, broken, and it's important to notice that. And once your eye is drawn to it, especially if you can magnify it, change your depth setting significantly on your probe, and still see with good clarity, and which gives you good confidence that this is very different from simple pulmonary edema with B lines. Here's a case, patient that appears to have normal pleural line, but then a subpleural consolidation of some sort, some abnormality. It's very helpful to be able to change the magnification. Again, you could go to a different probe, but in these times where a machine has to be contaminated, it may be nice to just be able to change your depth and define this area better, so that any B-line-like structures emanating from it are recognized as being reverberation artifacts rather than B-lines coming from areas of lung that are affected by pulmonary edema. Now, what about the heart? We shouldn't forget about the heart in COVID-19 patients. There is good literature that suggests 30% or more of septic patients will have some systolic left ventricular dysfunction, and it's important to assess and track for these changes, especially given that patients with cardiac conditions and elderly are apparently very susceptible to COVID-19, as seen around the world.
Are you looking at the heart of any COVID-19 patients to assess left ventricular systolic function? And have you seen any cardiac problems in these patients?
Yes, I do. Heart in COVID patients is an important information. It's very useful, and sometimes I find an imaging of suitable with congestive heart failure. And so this is important, but it's important also to know how is the heart before the COVID.
Very wise advice there. Don't assume an abnormality is new if you have evidence to the contrary or can't prove it. Now, it's very helpful to evaluate the left ejection fraction reliably. I have eyeballed ejection fractions since 1993, and sometimes I'm confident in them, sometimes I'm not. Where I lose confidence is when it's abnormal and I do something like start an inotrope and there's an improvement, but I'm not quite sure, especially if I last scanned the patient a few hours before, and in some settings, it may be half a day before. So if it's a relatively normal ejection fraction, even in a difficult to scan patient, perhaps you're all set, but it would be very nice in abnormal cases of ejection fraction to have an automated capability to assess the ejection fraction and repeatedly, and make sure that it's reproducible and hopefully automated and easy to use, so that even providers that are relative novices to cardiac point of care ultrasound are able to do this, and then perhaps have a different provider check and compare results a few hours later if that's indicated. Now, infection control, a very big topic. I think all of us have been thrown into this. For years, infection control was kind of the big gorilla in the room in discussions for point of care ultrasound. Yes, it's important, but maybe thought to be overdone by infection control administrators in various facilities. But now this has come full forward, or full turn right into our face, and we have to do something about that. We have to comply to various rules, and many people are realizing that, or really complaining about, that large machines are very hard to decontaminate adequately, especially if the decontamination measures prescribed by the individual facility are more extensive than before or more extensive than other facilities, and we're seeing this. Another potential problem that people have complained about is with handheld devices that run on people's individual smartphones or personal tablets, and then disinfection may be an issue. Can the device stand up to it? And what happens because you're taking that device home? Could you contaminate it there or contaminate your home and relatives, loved ones, etc., with what came out of the hospital in your pocket?
How are you handling disinfection of all the ultrasound equipment with so many COVID positive patients?
Equipment care is critical in the prevention of infection transmission. So to avoid contamination, I always cover the machine, the probe with disposable plastic, and then it's very, very important to clean the machine. However, at the end, the machine probes in the patient room after the exams, and also again in the hallway, according with the manufacturer's recommendations. Of course, using the disinfection, common disinfection, using this film pattern according with the manufacturer. I know that there are guidelines for disinfection of ultrasound equipment indicated from the American Institute for Ultrasound in Medicine that are very useful, I think.
This is definitely a big issue. We're seeing this on e-lists, discussion boards, and the range of responses by hospitals and medical systems is quite broad. However, it's very important to have a device that's specifically built for decontamination, that's appropriate and effective, and that can often be quite harsh as far as chemicals found in hospitals, and especially in this era. Interestingly, there was some work done in Australia 2 years ago approximately, that machines with wheels are exactly what various pathogens love to climb on and roll all around the hospital. So covering the machine completely is important, or perhaps disinfecting it all the way down to the wheels. And I must say, I never thought of cleaning the wheels on my ultrasound machine carts when I used to use them, unless body fluids somehow got onto them, such as in trauma patients or vomiting patients, etc. And it sounds like we may need to do that in many more cases, depending on how we're dressing our ultrasound machine. And this is where the new handhelds coming out that have come out really may provide an advantage, especially newer equipment that is due out soon, that images as well as almost any point-of-care ultrasound cart-based system, but is light, portable, and also made for disinfection specifically.
Do you think it is easier to disinfect a small or handheld ultrasound machine compared to a cart-based machine, or does it really make a difference?
Yes, I think that smaller machine, laptop-sized portable machine are more easily cleaned.
One thing that's not captured in this video, it's a discussion that happened offline afterwards. Dr. Caroselli mentioned that it now takes them 40 minutes to scan a patient because of all of the preparation and then the cleanup time, whereas before he and his residents might just take 10 minutes. And did note that the large machines definitely add to that, this is something that you have to consider when you're rescanning patients. It takes so much time, and also you risk, again, contaminating yourself or the equipment. So he recommended that people only rescan when necessary, but did say that he will rescan patients on a regular basis because they've had some kind of clinical change. Obviously be careful about disinfection, and not only from the compliance side, but from the safety side. And Dr. Caroselli reminded us several times during the phone call yesterday.
Do you have any advice for POCUS providers when facing possible COVID-19 patients wherever they are around the world?
If there is the suspicion that the patient may be COVID positive, use ultrasound, but they pay attention, careful attention to protect the machine, probes, and themselves to avoid the risk
He finished up by saying, avoid any unnecessary risks. And obviously, we've seen from the ELIS that
infect other persons and to finish the exam as soon as possible to avoid all these risks. So, of course, ultrasound is also in this occasion is a great resource for us, lung ultrasound. But remember that unfortunately the infection is near, so we can pay attention to the machine, the probes, to avoid the infection, to infect other patients, to infect ourselves.
Dr. Caraselli, I really want to thank you for taking the time to speak with us. There will be Focus and other listeners all over the world that will benefit from your experience and expertise as being one of the frontline fighters against COVID-19. Please be safe, and thank you again for sharing your expertise with us.
Thank you for the occasion to give my little experience, and the hoping is we will win very soon this virus, also with ultrasound, and that we will be all safe.
it's amazing that Dr. Caraselli took the time out of his schedule to be with us yesterday. This interview was recorded less than 24 hours ago, and that was after a full-length shift. I know he was exhausted, but definitely dressed extremely professionally, and was so kind to share his personal views and experiences with us. This is definitely a time for lung ultrasound to shine, and I think it deserves its recognition. It would be nice if it was for a less drastic reason, but sometimes in moments of crisis is when very useful tools like this come to the forefront. Many more are appreciating this now, and Dr. Caraselli specifically said that while he has enough equipment in his department and everyone uses it, a lot of his colleagues elsewhere in the hospital are now eager to learn about point-of-care ultrasound, starting to use it, and actually appreciating it for the first time. I think there are some great bits of research coming out, and there's more to come. Fortunately, I think we're going to have some good success with AI applications, not only in CT and COVID-19, but with ultrasound as well. And as we have new handheld devices come out that image as good as any carts, and have more and more AI applications to extend the diagnostic reach, not just in the hands of experts, but possibly the providers that have much less training than current users. I think that is potentially very exciting. Don't forget to look at that pleural line. It has a real story to tell. It's complicated, but it can really help you decide if the problem at hand is something like pulmonary edema or infection, inflammation, and this is especially critical in this time of COVID-19 pneumonia and trying to differentiate one type of patient from another. I wanted to thank you again for coming and listening. We do have a time period for questions. Probably the best way to take questions is to write them, and I will go through the questions in the question box and try to answer at least several of them. Thank you again for your time, your patience, and your attention, and I hope you've learned quite a bit from this webinar. All right. So the first questions are coming up. I apologize for the delay, it just takes a little bit. The first question is an excellent question. Since we don't have enough COVID-19 test kits in the US, do you think lung ultrasound can be a reliable diagnostic tool? I don't know that lung ultrasound right now can be used to rule out patients that have no symptoms as having COVID-19 because their lungs are completely clear. Clearly, anecdotally, we've seen evidence that asymptomatic patients who have abnormal lung findings are then testing positive for COVID-19. Interestingly, this is what was seen in China and in Japan with chest CT as well, but it wasn't 100%. So I think we need more data to come in. What it may allow us to do is basically screen asymptomatic patients and pull out more of the ones that are truly COVID-19 positive but have low clinical suspicion, so that we can still be more efficient with our testing kits until we have more available. And please feel free to add any additional questions. Again, I want to thank everyone for coming and listening. I know this is a very trying time all over the world, and I hope that this was educational. And again, entertaining may not be the right term at this time of crisis, but at least it provided new information. I apologize, I'm just trying to get at more questions. Let's see, here we go. Another question, will this information be available online for review? My impression is yes, it will be. Let me go through other questions. This is a new platform for me, so I apologize, I'm not facile. What do you mean by present settings? Settings to lung ultrasound on cardiac probe. There could be pulmonary edema on top of them. Basically, most modern point-of-care ultrasound devices will have ultrasound presets specific to the lung. Not every device, obviously. In general, that means tissue harmonics imaging, compound imaging are all turned off. As much post-processing as possible, because we know when you turn on tissue harmonics imaging, you can actually delete some B lines. Dr. Kometa, in his paper that I referenced in this presentation, has shown you could multiply the number of B lines, change their overall appearance if you're using compound imaging. So whether you're using a phased array probe, which is my choice because it's such a nice all-purpose probe as long as you can see the near field clearly and define it, or you're using a curvilinear or a linear, you want to make sure a lot of those post-processing features will be turned off. The pneumonia, as far as how it'll look on ultrasound, that's another question. I think we've seen here in COVID-19, you tend to have reverberation artifacts from abnormal pleura, as well as scattered and sometimes differently shaped and sized subpleural consolidations. And the other important feature that everybody seems to be reporting is bilaterality. In other words, found in both lungs. And I think Dr. Caracelli also noted this, inferior portions of the lungs and posterior, as the CT scan also supported. There's a question about, could you have pulmonary edema on top of pneumonia? Absolutely. I think the key is still going to be at the pleura. And one of the video clips I showed you, there was nice thin pleura, pleural line with B lines emanating from it. And then just next to it on the screen, you saw thickened irregular pleura. And in fact, I think I stopped and pointed out a subpleural consolidation from it, multiple very bright reverberation artifacts emanated down the screen. And that's a case where a patient with baseline pulmonary edema also had pneumonia. So it takes a little bit more detective work, but again, if you're paying attention to the pleura, that's a great way to sort it out. But that's an excellent question and shows for me, the complexity of lung ultrasound. One of the challenges I've always had is listening to the great lung ultrasound gurus say that it's so simple, anyone can use it, anyone can learn it, you almost don't have to learn it. I personally found that I needed more practice, and it took me a while to learn lung ultrasound. Someone said the sound has been a bit glitchy today, and I apologize for that. We will be able to give a recording so that hopefully everyone can see this. Going through a very tiny little box showing me some of the questions. Here's this is a great comment and question. Some of our Italian colleagues are recommending scanning everyone. Is this feasible since we don't have enough COVID-19 test kits in the United States? I think that is the answer. If we effectively can't test everyone, we have to be more strategic about whom we're testing. As I suggested before, perhaps what we could do is, out of the pool of patients that possibly could have COVID-19 but are much less likely, we could screen them with ultrasound. And if 50% or a little more, 60% of the positive ones, or the ones that would have been positive if we had enough test kits, had abnormal findings, then we could again select those and test them while we wait for more kits. I guess theoretically in that case, we could eliminate up to 60% of the patients with COVID-19 that we can't diagnose that would be leaving our care and perhaps infecting others. So that is just one possible application. I think our Italian colleagues now probably have better access to kits from what I understand, and simultaneously their use of lung ultrasound, I think, is much more ubiquitous than it is in the United States. Here's another great question. Should we focus on pleural findings instead of B lines? I think as is recommended by some of those greats out of Italy, probably the key is to focus on the pleural line first, and then look deeper and see if you're seeing simple B lines. And I guess when I'm scanning somebody, I usually have my phased array, every possible post-processing turned off, using a lung preset, a depth of about 10 centimeters, unless I'm in either quadrant, left upper quadrant of the diaphragm or right upper quadrant, in which case it's patient specific. And then I scan, and if I see B lines or possible reverberation artifacts and can't tell which is which, then I focus in on the pleura. Obviously, there are many patients I scan where I see no artifacts, then I don't have to focus on their pleura necessarily. It's only if there are artifacts, then I focus on the pleura to try to differentiate, is this pulmonary edema or interstitial lung process of some type? And obviously, for our topic today, could this be consistent with COVID-19? So I hope that is helpful. There's another question about disinfection, as Dr. Caroselli discussed. Remember, I think it's wise to recommend that you stick to disinfection procedures that are mandated by your facility. If you feel they're inadequate, overly draconian, it's something to engage in conversation. But we do want to make sure that we're safe, but also compliant with the rules of the facility, or perhaps the laws of the land. Let me try to get back to this question about the disinfection. It looked like a very good one. I apologize, I'm looking at all the text through this tiny little window, and I tried enlarging it, and it's just, I think, my lack of skill with it, and thus it limits how fast I can read. I lost that one, but in practice, amongst the patients you have seen treated, how clear are ultrasound findings different from COPD or edema findings? I think they're actually quite clear. The challenge comes in when you have a COPDer with congestive heart failure, and I see this on a regular basis. For my patients, which sometimes it feels like everybody has COPD because almost all of my patients seem to smoke, there is a tendency to only see really abnormal pleural findings like thickening irregularity in the more severe COPD patients or patients with other causes of pulmonary fibrosis. And in that case, it can really be difficult if they also have concomitant congestive heart failure. And in that case, I'll probably back myself up with evaluation of the inferior vena cava. Obviously, you could look at dilation of the hepatic veins and also flow and possibly flow reversal in our hepatic veins. So looking for congestion, but really probably just looking at the normal flow in the hepatic veins and seeing if there's increased flow or flow is affected somehow. There's a really nice reference to that from Dr. Philippe Rolla in Montreal. I believe it's VEXUS protocol. Some papers have come out, some are coming out. So that's great to kind of give you that extra edge for evaluating whether somebody might have congestive heart failure or not. And that is an interesting underline of the fact that when you have good ultrasound skills, or perhaps have a very smart device, you really have a very deep toolkit for deciding somebody has shortness of breath from pulmonary edema, chronic lung disease, a combination of both, and ruling out congestive heart failure in those patients. There are more great questions coming in. A lot of questions about will this be posted? And again, I believe it will be posted. The other thing is it may be useful to address some of these questions over email rather than trying to read them in this tiny little line. And I apologize. It looks like there'll be a lot of people's questions I can't get to. Let me try to sort through a few more. It's almost comical how they're appearing, but I want to reassure you all of your questions are important. Let me So this looks like a very good question. I find the nomenclature confusing. Yes, in fact, it's been confusing since it was first developed. The paper that hopefully will be coming out in a major ultrasound journal maybe this fall will seek to clarify some of that confusion. Part of the problem is the nature of point-of-care ultrasound. A lot of people working in silos, making up their own names. We don't have quite the conventions that are followed as rigorously as perhaps consultative imagers, and that's just what we have to live with, unfortunately. So yes, it's confusing, but the basic principle is B-lines from pulmonary edema should come from a normal thin pleura, directly from it, behave in certain ways, as I've discussed, whereas reverberation artifacts, if you're comfortable with that name, that are not related to pulmonary edema, come from the pleura, and a lot of times from an irregular pleura or disrupted pleura, abnormal pleura with subpleural consolidations. And if you start looking closely, a lot of times you will be surprised that after a few examples, you'll notice this. I discovered it quite a few years ago. I started noticing, even wanted to do a research project using AI myself as an academic venture, using AI to try to identify different types of pleura and correlating it. And along the way, realized that I was able to pick this out as well. I think we have about 5 minutes left. Really a lot of great questions. There's a question about irregular B-lines. Obviously, no rule fits everything, but it's a lot simpler when the machine has the correct settings. One of the things I see, even in publications, is that when the focal zone can be controlled, it's not set at the pleural line. And I think we have overwhelming and definitive evidence that that affects the way B-lines and reverberation artifacts appear lower down, so that can really interfere with your interpretation capability. Let me see if I can scroll through, try to find. This is a great one. Is there any evidence that lung ultrasound findings correlate with clinical course? That's the first part of the question. So not rigorously designed studies. I think that's something that'll have to be looked at retrospectively. Dr. Corselli, myself, and a number of colleagues are actually hoping to pool together some data retrospectively and analyze it to see what kind of patterns may correlate with outcomes. His ethics board, I believe, is on the verge of approving this. Several other IRBs are looking at it around the world as well. Others will have to look later because of the crisis situation we're in. Regardless, this will be a retrospective project that as much data as we can get, the better, because I think we probably will be able to predict people's course, whether it's just from one scan or progression of scans. It's unclear, but I think this is a very exciting area. Just like it was interesting for AI and CT of the chest, this may be an area where AI can really help ultrasound be predictive as well as diagnostic. How much should we weigh concerning lung ultrasound findings in relatively asymptomatic patients? Again, no one has addressed this directly, and the data is really scant, period. But if you look at the CT studies, I think one had 54, 56% with lesions, patients that were asymptomatic but COVID-19 positive. Similarly, we're hearing this around the world from ultrasound users. So it's up to you. I think it's hard to make an evidence-based or even a close to an evidence-based recommendation, but depending on the clinical setting, that approach could have merit. But obviously, if you don't have the testing kits, perhaps you want to rethink that and look at your overall workflow. I think at this point, we'll probably go ahead and thank everyone for joining the webinar. Again, please feel free to reach out. If I didn't get to your questions, there were so many great ones. I could only see them one little line at a time as I scrolled, and I apologize for my technical incompetence with this platform, but it seems to be working well. And I know I really enjoyed putting this on for everyone in the audience, and really thank Dr. Corselli for sharing his experience with us as well. Thank you very much.